Good morning, everyone. Welcome to Connecting for Better Health. And our workshop today focused on health AI. Super excited to see you all, and even more excited that many of us were able to see each other in person over the last couple of weeks as we've been on the road. Connecting for Better Health on the road. Detroit, let's see, I'm trying to remember. Detroit, Las Vegas, Palm Springs.
What was the Palm Springs activity?
Palm Springs was the California Association of Health Plans.
Oh, yeah, that's right.
Yes, back to back.
Now
All
I've got
right.
now I've got triple the FOMO.
We all do. Okay, well, let's get started here. It looks like we've got our esteemed speakers that we are really excited to be able to have this conversation today. And I really welcome everyone to jump in as our workshops are a real focused event where we want to be able to evolve our conversation and our decision making. Just brief about our coalition. If you're new, Connecting for Better Health, we are dedicated to advancing health and social data sharing in California. And our policy priorities that we've been following this year to be able to advance the data sharing agreement and the data exchange framework, to really be able to identify funding to be able to have California draw down its fair share from federal sources, as well as to be able to make sure that we have a sustainable path forward. For us to always keep social services at the front and a seat at the table, and then finally to be advanced governance and enforcement that we spent quite a bit of time on, and we'll continue to do so next year. These policy priorities are set by you and our advisory board and our leadership board, and it really advises us as staff to Connecting for Better Health, how we bring to you our programming, our curate our newsletter, and also be able to advance where we put resources into policy and advocacy. Next slide. Before I move on and introduce the workshop today, as we always do, if you could put your name and organization in the chat. Check and see in Zoom if your box has your name and your organization. It helps us out quite a bit so that when we call on you, we know who you are and your organization. And also, as we say, and we're able to demonstrate this as we were on the road, so much of the power of our coalition is the networking we do with each other. In this meeting, as we have it twice a month, but then outside of the meeting. So please, let's use this as a fantastic networking capability. So as we prepared for today, and I really have to give kudos to our team, Olivia Bundschuh, Stephanie Thornton, Maya Harrison, for putting together such a really robust and thoughtful agenda. And I think this diagram that we put together in the spirit of Venn diagrams, and I think QR codes are having a moment. But in the spirit of our Venn diagrams, we put this visual together that I think we will be evolving, and it'll evolve real time today. How do we really focus in on that intersection of AI and healthcare focused AI and data sharing? And how can we think about data sharing and the governance and the quality of making sure that our data sharing is the best it can be in order to drive even better AI outcomes, or AI related outcomes. So I think we're just as we were all pulling together the agenda today, at least I feel this personally, we're at the beginning of a really incredible journey. And I think many of you and our experts on the call today would say, well, we're not at the beginning. The beginning was several years ago, but I do think that we're going to have quite a bit of time being in an accelerated mode, playing catch up and making sure that our policies and our regulations are there to support the advancements that we're seeing. So that's really my view as we're looking forward. And I'll just give it as another, just in terms of setting context, as we were just talking about being on the road these last few weeks. And our friends at Civitas will be here today. Their leadership is just, and their conference was, that was just remarkable in Detroit for those of you who joined. I'm sure you'll agree. But on the main stage was a session around how AI is going to shape our future with Mickey Tripathi from ONC and others. And I think it really helped formulate today's conversation. But then right after, many of us were at Health, the conference, really advancing digital health in Las Vegas. And again, AI was throughout all of the sessions, not all, but at least all of the programming each day. There was quite a bit of excitement and thoughtfulness around health AI. And one of my big takeaways from an event there was this new term, explainable health AI. Like, we need to endeavor to be able to have that transparency and for us to be able to explain to others how useful and the efficacy and safety. So that was my big takeaway. But then my third takeaway is, as going to CAP, the California Association of Health Plans, very little discussion about AI. In fact, we were all readying for today's call, and I don't think we heard it at all amongst our team. So we've got a lot of work to do. And so here we are today. So I just quickly, our agenda. Oh, thank you for the workshop objectives. Let's ground us on the objectives. We are seeking to advance understand federal and state activity, what's underway, and where there might be gaps. Consider, as I just presented the Venn diagram, what are the linkages between health and data sharing, health and social data sharing, and health AI? And then also, we as a team really want to get a jump start on informing our policy priorities for next year. What type of education, programming, and advocacy and policy need to be in the center of our work going forward. So next slide. Here's our agenda. We thought it would be great to spend just 5-10 minutes on grounding ourselves so we have the same vocabulary. I'm constantly seeking, as I'm in these discussions with AI, I know I'm learning, but where and how can we have some grounding vocabulary so that we are all speaking from the same page? Also, we want to review with you what we've been tracking this year with the legislation around AI and what the governor just signed too, just to be able to give a sense of where we are at the state policy level. And then I also love the crosswalking of what the feds are up to, our federal leadership and our state leadership, and where there might be some synergy and gap. I said the word synergy, I try not to. And then we move into our presenters today. So we have our leader from Valid AI, and we also have our friends at Civitas that we are really excited about the work that they're doing and the research they're publishing and how that will guide our discussion. And we do want to leave enough time in our session today just to have a good discussion where we'll open up to everyone. But as we always do, we really welcome your questions as we have our speakers present. And then we'll just quickly wrap up. So with that, I'm going to hand it off to Olivia with our introductions.
Hi, everyone. All right, let's lay some groundwork to get us kicked off today. So we want to just start by level setting on what is AI and also what is health AI, how is it being used today in healthcare. Artificial intelligence is a technology that enables machines to simulate human intelligence, which can mean a lot of different things, ranging from learning, comprehension, problem solving, decision making, and even being creative and having autonomy. AI builds, from the most basic, simplistic type of AI that you'll see is called like reactive AI. And this is AI that's programmed to have a predictable output based on the inputs it receives. It's going to be an algorithm that responds the same exact way to identical situations every single time, and they're not able to learn. But as algorithms get more advanced and you move into machine learning, deep learning, algorithms have the ability to analyze data, learn from it, and actually make decisions. Machine learning may start with just one single algorithm that has the ability to learn. But as we get into deep learning and generative AI, we begin to see these multi-layered AI networks of multiple algorithms and models coming together for better generalizations and having more scale. A lot of the AI policy that you'll see coming out from both the state and on the federal side is really looking at generative AI. And this is AI that not only has the ability to learn, but it can actually create fully new content from the inputs that it's given. So totally new outputs based on the data that it's trained on. And this can range from, text, images. I'm sure we've been seeing it for music, videos, and even code as well. So that is our basic breakdown of what AI is and how we're going to look at it. And again, most of our conversation today is going to be focused on generative AI that has that ability to create new content. And to also just level set on, how does this apply to healthcare and how is it being used in healthcare today? I'm sure people have seen a lot of discussion around the different tools that are now available to providers to support documentation, administrative workflows. But, it's also being used in patient care today for helping with medical diagnosis, analyzing images to detect conditions, and even to support treatment. There's AI that can simulate different treatment models and predict the outcomes patient outcomes that may be linked to those different treatment approaches. And of course, AI is definitely being used in research to advance clinical trials. We're seeing it in the White House Cancer Moonshot Initiative, AI being leveraged there. And I would say most relevant to our work today and where it's also being used in healthcare is around data management with all the data that we have. To clean data, extract information from EHRs, integrate it, and help organize it in general. So let's move on to our next slide. While we're very aware, I would say, of all the different potentials and benefits and advantages of AI, there is a bit of hesitancy and a focus as well on making sure that it's being used responsibly and not producing bias and harm. The data that we're feeding into AI is inherently biased based on the healthcare system that we live in today. And this is a quote from Dr. Miki Tripathi, who's our chief AI officer at HHS. But I think it really rings true to how we should be looking at AI and considering the data that we're feeding into it and, the impacts it can have down the line. If you looked at the survey results on the right screen here, physicians are excited about using AI. There's a survey that came out recently that there's been more rapid acceptance among providers or among physicians, with 68% actually having changed their views on AI in just the last year, and being more likely to think that Gen AI has benefits to healthcare. But as you can see from these results here, there is a call for transparency and for assurances to make sure that the AI that they're using for their patients is safe. And I provided a few different examples of the different biases that that have come up in algorithms. One focused on or found that some algorithms that were using race as a factor were actually flagging patients for extra medical care, or white patients for more medical care versus Black patients. There's been evidence that this bias in algorithms can exacerbate social inequities. And there was another example not too long ago that an AI tool was actually double booking lower income patients who were more likely to miss appointments, which I saw actually this week when doing research for our workshop today, that a health system was very excited about the ROI that they've gained from this, but it does have implications for patients on the back end. So we need to make sure that the AI, the data going into it is not biased, and the way it's being used is not harming patients at the end of the day. Moving into our next slide, I wanted to just quick touch upon as well how AI is developed and the different opportunities for governance and insurances that we may consider in California, and we're seeing the federal actions look at as well. Beginning to develop AI really starts with training the data that goes into it. There's been an opportunity for governance might be around transparency in the types of data that's being fed into these algorithms. We then move into validation, which is ensuring that the model is doing what it's supposed to be doing. And we've seen different policy actions around ensuring guardrails on how AI is being developed to be used. We then get into deployment, making sure it's being applied in the right situations. And there could be regulations here around what permitted uses might be applicable and are safe and beneficial and responsible for patients. And finally, monitoring. So tracking what it's doing, making sure it's happening It's doing what it's supposed to be doing in real world conditions and not causing harm. But then there is this continuous cycle of improvement that happens, once AI is deployed and new data is getting fed into it, new models are getting fed into it to make sure that it's precise. So I thought that this was just a helpful way of looking at AI to understand the different opportunities for assurances.
And Olivia, I just want to do a quick time check too, because we want to be able to.
Yes. Okay. I will move right on to our federal actions impacting health AI. The White House started with just announcing that commitments with AI developers. They moved into releasing an AI Bill of Rights, an AI Bill of Rights blueprint to outline principles for responsible AI. But the most significant federal action to date is really focused on the executive order for safe, secure, and trustworthy development and use of AI, with many directives for federal agencies. This graphic at the bottom focuses on the key directives for the U.S. Department of Health and Human Services. Significantly, each department has been required to assign chief AI officers, with Dr. Mickey Tripathi of ONC, now ASTP, also now jointly acting as the acting HHS Chief AI Officer to oversee the HHS AI strategy. The executive order also prompted HHS to develop a use case of an inventory of all their AI use cases, and to share the codes that they're using as open source to make them publicly available. They've also been tasked with creating a safety program to receive reports and address reports of harmful AI practices. And finally, there's also work underway, which I believe we'll be seeing more next year, to develop a framework for assessing and monitoring AI performance quality with a federal HHS AI task force. And two other points to note before we move on to the state actions. The HTI-1 final rule that came out of ONC earlier this year actually has some AI algorithm transparency requirements. I believe it's 31 data elements. So if an EHR is using AI, they must disclose how they're using it through these elements for EHRs that are certified health IT. And this will kick off next year. So it'll be very interesting to see what gets reported there for improving AI transparency. And finally, at the beginning of next year, we anticipate seeing an HHS AI strategic plan. So more to come. And to keep us on time, I'll quick run through as well our California state actions related to AI. In September 2023, Governor Newsom released his own executive order related to AI to prepare state departments and agencies for progress that's to come. A lot of it is focused on studying, the development, the use, the risk of Gen AI. But there have also been directives to create guidelines for procurement, how state departments and agencies will be procuring AI and using AI. They commissioned a report on Gen AI risks and benefits for state agency use, and also guidelines for assessing Gen AI adoption. The Cal HHS IT and Data Strategic Plan also had some AI references in it. Not too much, but they did make a nod to the need for identifying opportunities and guarding for risks for identifying Gen AI opportunities and also protecting against risks. They do note that Gen AI requires measures to address insufficiently guarded systems and harms, and they are looking to ensure responsible Gen AI use using the guardrails that were developed in the previous executive order, and making sure that's getting carried throughout Cal HHS. Recently, we had 17 bills that were signed by Governor Newsom relating to Gen AI. And the state has also announced a few new AI-related initiatives, nothing in particular focused on health AI, but setting the general groundwork for AI use in California. And I will pass it over to Stephanie to dive a little bit deeper into the many bills that were introduced at the beginning of this legislative session, and what was actually passed, and we'll see becoming enacted next year.
Thanks, Olivia. I think we can come back to our legislative table at the end of today's session, but One thing that I just wanted to mention was, in addition to the 17 bills Olivia just mentioned that were signed, there's also, of course, a couple notable vetoes. I think the bill that, garnered the most media attention, this last one on the list here, Senate Bill 1047. The governor's veto message on this specific bill is interesting for many reasons. We can put a link to it in the chat, but one, just want to highlight before we move to our speakers, is a line in there about how he signed many bills this year regulating specific known risks posed by AI, but rejected this bill in part because of the belief that it would have applied stringent standards to even the most basic functions. So anyways, I think just one key takeaway from this list are the legislative actions that we saw this year is that balance, or potentially that policy tension between specificity and broad applicability. But we'll come back to, I think, our legislative pieces at the end of today's discussion. If we move on to our next slide, I'm really excited to introduce our first speaker today. As Timmy mentioned at the beginning, we're thrilled to have the Valid AI Initiative on today's call. The Valid AI Initiative was founded at UC Davis. It comprises more than 50 health organizations and systems across the nation now. And Valid AI is just one of many initiatives that have begun in the past couple years on this topic, like CHAI, the Coalition for Health AI, or the Health AI Partnership. We have listed here just for reference or further reading for those interested. But similarly to how our legislative list is likely to be 2 times or 3 times as long, next year and the years that follow, I'm sure we'll see more of these grow as well. But with that, I'm going to introduce Dr. Kamal Jethwani. Really appreciate you being here today, Dr. Jethwani. Some of Dr. Jethwani's recent work includes incorporating connected health solutions with AI and machine learning strategies to create personalized and predictive programs for patients, as well as strategies to integrate those into clinical workflows. So, Dr. Jethwani, I'll turn it over to you to introduce us to the Valid AI Initiative.
Thank you. Thank you so much for having me, Stephanie. And I apologize, I was at health earlier this week, so I was a little bit choppy in my responses, but appreciate you having me here. And really, congratulations on the network here and the community you've built. It sounds wonderful, and very excited to be here presenting to this. Would I be able to share slides if you allow me to share?
You should be good.
Great, awesome. Thank you so much. So I'll just start by saying, I've been doing health innovation now, digital health innovation, for about 20 years. And over the years, have realized that innovation is not an individual sport, and that we have to bring like-minded people together to really think about how we create innovations, how we scale innovations, and what makes meaning for us. And this could not be more true than at health systems. So I take a little bit of a health system view into innovation, and I want to kind of just share a little bit about how we're thinking about AI in general, but also kind of how we are able to get adoption on scale. So usually, before we even get into it, the question I often get from people who are trying to work with health systems is, do you guys ever need to innovate? Like, is there a imperative or a reason why that is important to you? And if you look at some of the numbers that are really true after COVID, especially, they're pretty astounding, right? So to begin with, we see our costs, especially labor, go up by 25% over the last 5 years. Yet our hospital expenses have increased by about 18%, but our reimbursement has only increased 8%. So now we're seeing significantly higher cost of delivering care, and the reimbursement for delivering the exact same care has only grown so much by leaving a pretty big gap in the middle. What that has actually done is it has led to a lot of hospital closures. It has led to a lot of our communities being left stranded without the care that they were expecting to get and that they were hoping to get, which exacerbates access issues in our communities, especially in rural areas. What we're also
if I could jump in real quick, we are looking at our time here, and we really need to focus on the Valid AI Initiative because we're super interested in how can we gain that. I think in terms of the background and all of that, like, I'd love to be able to advance the discussion to the more of the collaborative.
Absolutely, we'll do that. Again, just as I was going, penalties going up, patient experience is tanking over the last few years. So as we start to think about what do we do there and how do we actually make it happen, what we've come to realize is that innovation is not as straightforward and is difficult to achieve, even though there is a pretty significant imperative to achieve it. So our philosophy is really thinking about how do we get to a future where we can work together and create some of these communities of innovators to be able to advance the mission and the agenda. So this is sort of our framework for communities, and I have a few that are important to talk about. So our basic framework for organizing communities is to start with organizing people and organizations that are non-competitive around a mutually experienced unmet need, articulating or helping them articulate some of their unmet need across the membership, prioritizing these unmet needs and sort of form that as a list of communities, priorities within the community, matchmake solutions and consumers of these different priorities, and then be able to sort of actually test and scale solutions and really figure out how we standardize some of this. So the goal of all of our communities is to start with some of the areas that we're really interested in innovating in, and then following this 5-step process on the other side to actually create evidence and create ways in which we can standardize some of these best practices and be able to sort of take that model and be able to replicate it across our entire membership. Our very first community in this, as mentioned, is Valid AI. So Valid AI is basically execution focused and is aimed at bridging the gap of all the efforts that we have coordinating generative AI solutions within healthcare systems. Today, we have health systems in all 48 states, so about 50 health system collaborative, and you can see some of the example members here. And the way we're organized, it's 8 founding member organizations led by UC Davis. And then we have about 42 other members, including health systems, mostly health systems, but also including some organizations like CHAI that are also members. We do a bunch of different priority areas. So we bring the community together twice a month, and we talk about what the different work streams are and what we need to do in that. We successfully finished one work stream around digital scribe solutions, and we started a second work stream 3 months ago around social determinants of health. And so one outcome from that work stream that has come out that I'm excited to share with you guys is the launch of a social determinants of health accelerator using generative AI solutions. So we're launching an accelerator where our goal is to make social data or social determinants of health data a social vital sign. What that means is we want to bring this data and capture it in a way that is actually brought forward at the point of decision making, so that we are taking clinical decisions in context with patients' social data and making that available, that data reliable, accessible, easily connected to decision making, and be able to provide our patients with better care. Today, this is very fractured and it's happening in 40, 50 different ways across the country. We think that generative AI has a real potential in bringing some of these data streams together and helping us make headway into this. Our sourcing areas in this are around data collection and extraction, integrating the data, workflow assessments, and reporting and analytics. Happy to share this forward afterwards, but we're looking for additional health systems and other partners to come in and sort of complete the collaborative here on helping accelerate ideas and co-developing some of these ideas around SDOH.
This
and then,
absolutely shares our DNA, and I'm sure there will be follow-up. And I think what we could do, I mean, this is incredible. And why we're here is to learn about these initiatives that are going on. Could we then move on to our additional speakers at Civitas and then bring you back to the discussion around what you need from us and what would you need at the state level, unless you want to pepper that with us right now before we do that. But I'd love your expert thinking.
Absolutely, I'm happy to come back. So I'll turn it over to you then.
Okay, all right, let's do that. But fair warning, I'm going to call on you. Okay, so Stephanie, and well, I'll go ahead and introduce Jolie Rizzo and Ahmed Alcazar. We are so happy to have you, and what great timing to have the paper that was recently published around how HIEs and health data utilities can help to be a really great contributor to transparency and validation. If we can, Jolie, I think you're on, and you can also introduce Ahmed, Dr. Ahmed.
Of course. Hi, everyone. It's great to be here. It's great to see a lot of familiar faces. And Timmy, thank you for the shout out for the conference. We had a lot of fun in Detroit. It was our biggest one yet with over 800 attendees. And Civitas, we can jump to the next slide, is really all about, convening our members from across the country who represent, multi-stakeholder health data collaboratives in various capacities to really think about, how do we actually bridge data and doing. And I wanted to just acknowledge that today my co-presenter Ahmad Alkazir was one of our keynote speakers on that AI panel that Timmy referenced. And it's been really a delight to be partnering with the Ellison Institute for Technology in this sort of effort to further explore health AI governance and the potential opportunities of HIEs and health data utilities in doing this. And yesterday I was on a call I'm participating in the HIMSS HIE and Interoperability Forum Committee and developing sort of the agenda for that forum. And it was noted as, how AI can help HIEs. And I just said, we might want to flip that. It might be more about how HIEs can help AI. And so that's what we're here to talk about because there is tremendous opportunity. So let's jump ahead a couple of slides. I'm not going to go into too much detail about who Civitas is, but if anyone listening today has curiosity, don't hesitate to reach out. We're always happy to share more. But really, our network represents implementers. We, again, as I mentioned already, we represent health collaboratives, which, may be health information exchanges or all-payer claims databases, quality improvement organizations, and other collaborative type entities that are bringing together payers, providers, purchasers, patients, public health, and so on. And that's really relevant to the conversation about how HIEs or HDUs can help AI, because we know that for AI governance, it's going to have to include public-private patient partnerships. And many of our Civitas members are already sort of, that infrastructure is already built, and they're very sort of, community-centric and established within states and regions throughout this entire country. So let's keep going. And again, we're just all about this idea of how do you bring sort of high quality, robust data sets closer to those who are then going to take that data into action and further, critical advancements in health and social care. Next slide. So we're talking about health data utilities, but I don't want to get too hung up on the terminology itself. It's far more about the functionality. And so it's really about this concept of having regional or statewide entities, likely nonprofit entities, that are working to combine, enhance, and exchange electronic health data across care and service settings for treatment, care coordination, quality improvement, and public and community health purposes. So health data utilities are, again, these health data sort of collaboratives that have the ability to serve that purpose for, quality improvement, public health, their sort of state partnerships. They do need to be sort of set within a geography and have defined use cases. In this case, we're talking about health AI and governance, and there's a real, I would say, building use case around this. So wanted to just, introduce that concept because Ahmad's going to talk a little bit more about the paper that we recently just published in the New England Journal of Medicine around this concept. So we can jump to the next slide. And again, when we think about AI governance, there's some things that we are getting clearer on, which is, we do need multi-stakeholder governance. That's super important. We're going to need probably some level of designated authority for who's going to govern. It needs to be inclusive. There needs to be a high level of focus on security and privacy. And we need to make sure that, we have true stewards of the data so that we limit, AI hallucinations and model drift and other issues that can come up pretty quickly. So all this to say is there's already this tremendous existing infrastructure we can likely build from, and that's what we're talking about. So I'm going to pass it over to Ahmad, not to take up too much airtime. If anybody wants to follow up on anything I said, I'm here and happy to take questions.
Great. Thanks, Julie. Ahmad Alkazir. I'm from the Ellison Institute of Technology. I serve as policy program manager here, and my department serves like a think tank for our institute. So my goal is to give you really a quick rundown of what we do, how we got involved into the health information exchange space and health data utilities research, and then talk and summarize briefly our paper in the New England Journal of Medicine's AI journal, which was a policy perspective piece. So next slide. So Ellison Institute of Technology, our mission is to develop and deploy technologies to solve, challenging and enduring problems, whether it's in health and medicine, sustainability, government innovation, and artificial intelligence. Next slide. So we have two bases, one in Oxford with a partnership with Oxford University, but I'm based out of Los Angeles' campus, which was established in 2009 as a cancer care and cancer research center. And really, we have clinicians, scientists, be it chemists, biologists, physicists, all working together under one roof to translate lab innovations into point of care solutions for patients and to improve patient outcomes. And so if you go to the next slide, the way we visualize this is with the patient at the center. And we have a multidimensional view of how we can improve patient outcomes through labs, collaborative science, cancer care, but also through education, prevention, and wellness. And one specific aspect is the data arsenal. Like how do you establish a data arsenal to rely on all the digitized workflows and research data to enable improved patient outcomes at the point of care? And that's how our team got involved in, learning about the roles HIEs are playing with care coordination and the challenges and barriers, be it technical or regulatory, to reusing data or secondary uses of data for research, for public health, et cetera. And so we can go to the next slide. And that eventually culminated, that eventually culminated in the New England Journal of Medicine publication discussing data reuse and its implication for health AI and the role of HDUs in developing, testing, and regulating AI. And so our key argument here is that, in order to translate AI from a tool that is used to actually improve health outcomes, you really need to improve and modernize health systems, regulations, and governance structures for the AI era, specifically to enable robust model development on high quality data, validate rigorously the model prior to deployment, but even after deployment, you need to check for safety and efficacy through time, otherwise known as AI assurance functions. And what we're essentially saying is, just like any other uses of secondary data or health data for a secondary purpose, AI development is just that. It's a secondary use of data. You're relying on AI, on health data to develop AI models, then give you recommendations at the point of care or give public health, population health recommendations. And what we're saying is, for that reason, AI developments would benefit from modernizing capabilities and governance for clinical data, public health data, and other data types across the health ecosystem, right? And the other thing we highlight in the paper is there's some congressional recognition going on right now. HDUs were defined in Senate Report 11884, and it directs the CDC, ASTP, ONC, and other agencies to support state-designated health data utilities. And again, I emphasized Jolie's point earlier, we're not hung up on the terminology of utilities, we're really focused on the function of utilities, and what a health data utility looks like, what's the org chart, will vary from state to state. And so next slide, please populate it as well. There you go. And the way we've split our arguments in the paper is similar to what Timmy, like the diagram of health AI and data sharing. And so we view health data utilities to have two potential roles. One in data governance for AI, but also for AI governance itself and the governance of models. And so when you look at the data side, HDUs could serve as state-designated entities responsible for collecting and standardizing data, enabling aggregation of more comprehensive, multi-source, representative, local health data, right? And they would formalize the standards and governance, enable integration of clinical and non-clinical data, which is really useful for models that rely on both data types, but also on aggregating clinical data from multiple sites. And you have a lot of models that rely on EHR data from multiple sites. And we envision HDUs providing clear provenance, ensuring data quality, and also enhancing privacy and security safeguards, which is also another factor that it's not being spoken about enough yet. Although this is one of the main reasons why the industry is not adopting AI models quickly. And so all these functions we think are critical for ensuring AI safety, effectiveness, equity, and even explainability, as was mentioned by Timmy earlier. And then the other thing is that through these capabilities, health data utilities could be the public stewards of validated data sets, which would do two things. One, you could host these data sets for developers, providing appropriate access for AI developments, or you could provide de-identified data based on that the data sets that you have through the HDU, but you can also create synthetic data with similar data structures, which models could also utilize. The other thing is that it would promote a fair and competitive AI ecosystem, which was required by the White House executive order on trustworthy AI. And so if you think about the ecosystem as a whole, organizations that have access to vast amount of health data have an unfair advantage on AI developments. And the goal here would be that for HIE networks and HDUs to level the playing field for small and medium sized organizations. We can move to the next slide. Also populate it, please. Thank you. And then, so that's what HDUs could do pertaining to data governance. But there's certain things about AI models themselves, and I think Olivia touched upon it a little bit, that warrant or point to the potential of relying on HDUs and HIE networks for governing AI models, not just the data that fuels AIs. And so if you think about it, there's risks in deploying health AI. You could exacerbate inequities. You could cause unintentional harm. But there's also evidence to show that models could have prospective performance decay just with subtle changes in the data structure compared to the data structures that the models were trained on or tested or used for testing. The other thing is that there's been simulation studies where they've simulated health systems deploying more and more AI models. And what they've seen is that these models start to interact with one another across digitized workflows, also leading to performance decay. But then the other thing is you could look at it from a regulatory perspective. AI is much easier to develop. It's still difficult in many instances, but it's much easier to develop than drugs and devices. And so you might overburden the FDA's capacity for oversight. But also, the FDA can't regulate all models, and many models fall outside the FDA's purview, such as models in public health surveillance, health administration, and other types of models. And so what we say in the paper is, look, HDUs could potentially support not just data governance, but health AI governance. One, by promoting state and federal guidance and AI assurance policies and best practices, but also by supporting the evaluation and life cycle oversight of the model. I think, Olivia, you shared that the 4 boxes of the life cycle of an AI model. And because of these characteristics of AI, you really need some localized recurring testing and transparent reporting on these testing. And so you could either develop the model on local HIE data, or you can bring models that have been developed on other data sets outside of your localities and regions and test them on your local data sets. And for deployed models, you can prospectively and continuously monitor performance in localities and regions. And you could assess performance not just from an efficacy standpoint, but from an equity standpoint, fairness standpoint, and other ways to look at AI validation and performance evaluations. However, there's need for mandates and incentives to establish these functions for HDUs and to transition HIE organizations into roles that go beyond care coordination and enhanced secondary use of health data, including AI development. And so with that, we can move to Q&A, but if we don't have time, we can move on to The
Well,
next center.
it's absolute great setup. And I just saw that from Valid AI is Anne, are you on? If you could jump on with your camera. Do
I am on. Thank you.
you want to just quickly introduce yourself as well?
Hi, I'm Ann Stadhar. I work with the Valid AI team and help run that community along with Kamal. So nice to meet you all.
Thank you, thank you. And I'm sorry that we lost Kamal, but thank you for being here as well. And I think that if we can go to the next slide, I'd love to be able to kind of really zero in with your experience at Valid AI, as well as Ahmed, what you're seeing and what you laid out on where we need more, state action, if you will, and or local or policy action in order to be able to kind of bring forward your vision as well as the action that we all are looking at in terms of implementation. And I just to get this conversation started, the whole idea of governance, when we say governance, I think about it at the state level of being able to govern an HIE construct and making sure that we are ensuring that all of us as Californians and all of our providers have the same access to the tools that are needed. And then you move that down to a local governance when you look at different health information organizations or HDU or HIEs, where that governance also has such an important role to make sure that they're meeting the needs of the community. But then what I'm also hearing is that there's another whole level of when we say governance, which is the governance of AI and AI models. And I think what you are advocating, Ahmad, is that they can be the same, that governance model can do both. But I was wondering if you could just unpack that a little bit more, because that was really a bright light for as I was listening to the discussion.
Yeah, great. And Jolie, feel free to jump in here as well. So as I mentioned, there's already a lot has been done from high tech up to today on governing health data sharing, right? And what we've seen in our research is that, there's already been even further developments at the state and local level to rely on HIE's infrastructures that they have at localities and regions for secondary uses. And, if you look at the COVID experience, states and regions and HIEs that had the authority and the mandates to rely on, health data, EHR data, and feed those into pipelines for, on the ground situational awareness on, who's getting infected, are they vaccinated, et cetera, have managed the pandemic better than in areas or with HIEs that couldn't do that or didn't have the authority to do that. And so what we're saying here is that, look, if we want to enable AI development in a safe, explainable, equitable manner, it's not sufficient. Like there's been proposals out there that, oh, let's just get some third-party labs, have them test the model, give it a stamp of approval, and then deploy it. The problem is that these models, it's like trying to regulate a moving target. Not all these models are fixed, and they could adapt with time. And a lot of these models are not even regulated by the FDA. And so you need some sort of distributed network approach to regulating these models and measuring how effective they are through time across the whole life cycle. And as communities, health systems, and states and localities and regions start to deploy models, what we're saying is that, look, you have the infrastructure, you have the local data to test performance and conduct oversight where the FDA can't or where ONC can't. And so that's what we call for in the paper, is taking a step back and looking at, we've established a lot of governance for data sharing. Could we bank on that and build on it to enable health AI governance where the federal government doesn't have enough purview or mandates or authority at the state level, local level, to regulate how health AI is used on which populations. And so that's what we call for in the paper. Does that answer your question?
It does, and I think it really expands the definition of when I think about governance and stewardship and frankly, the utility and the importance of our data exchange framework, where we have a governance model. You know, I have to say with right now a smaller lowercase g, we're looking to be able to put that into legislation. But you know, with advancement of our work at the work at CDII and the work of all of us in California with advancing the data exchange framework, I think we have something of a construct that can be really useful. I see Kamala's back, and I'd also love just be able to kind of help with the bookend of your presentation. As you're working forward, I think many of us are extremely interested in the work on social services and SDOH. And what are you seeing, and where, if you could bring it back at a state level, do you see the need for more governance and or state guidance, I guess, if I zero in on that question?
No, that's a wonderful question. So the reason why our health system sort of, voted for this as being a really significant use case was because there are actually a lot of state issued mandates around data collection in the space. And so we're getting asked by Medicaid to collect some of the data. We're being asked by, Department of Public Health in California to be collecting some data. We're being asked by federal agencies. We're being asked by commercial contractors, value-based care. So there's all these different forces asking us to collect data in different formats. In some cases, actually the same exact data point in 4 different ways and 4 different points in the patient journey. And now if you think about it, I get those data points back sometimes as a PDF, sometimes as a structured field, sometimes in an encounter note that is unstructured. And I don't really have a way to reconcile it. And even if I do, if the patient answers it differently in 2 different places, I don't know which one's right. And so how do I take that mess, pardon my word, but how do I take that and actually make it effective in decision-making? And so we said, as a coalition, do we go the governance route and try to get, someone to like organize this? Or do we go the innovation route and say, let's figure out how to use the magic of, ChatGPT, for lack of a better word, to actually be able to sort of make some sense out of this so that we can move into this, aggressively. And given our membership and representation, I think we chose that route. But really through the challenge, we're trying to say, there is a real business case for health systems to do this right. There is a real case for patient experience and patient, sort of patient-facing appropriateness. There's a real case for clinicians who want to do well by their patients and actually use this data and just are being, are not being helped because they don't have reliability and validity of the data. They don't trust anything that's in there. And I'll just use one of my favorite examples of why this work became so important for me personally. In our health system, we had a patient that had gone through 2 rounds of cancer and had gotten into remission both times, and she had just come back to our system a 3rd time. And this 3rd time, she had lost her job, didn't have insurance, had food insecurity, had housing insecurity. And she told us so on a state-mandated form that we were required to collect and put as a PDF in our medical record. We collected that information. She told us everything. We put it in as a PDF. No one saw it. And at the end of the treatment, she was stuck with a $35,000 out-of-pocket bill. And that makes us look tone deaf. That makes the patient suffer. And as a system, we're not making it work because the state that told me to do it also didn't really ensure meaningful use of the data. So that's kind of where we want to go with this, and we'd love your support.
That's super. Thank you. And I think, we do ground ourselves a lot on priority use cases, and that use case is very specific and near and dear to all of us. I would love to open up for questions and or additional insight. Jim, I see you're ready to go. Thank you. Yes, please.
Yeah, and I don't want to state the obvious because I think thematically this is what we've been referring to, but to be kind of explicit about it, I think between the existing model and discussions in Civitas, excuse me, around the transition from the HIE-HIO to the HDU model, it's around value add for the data and recognizing the position of data exchange as being one for value add for all the factors you have in the Venn diagram. And now what we're talking is how do we apply autonomous processes, enhanced insights and the like onto that data to, the way Kamal described it, either yield better results for the patient and whole patient care to automate or streamline processes for analytics. And it seems like the one thing we hadn't really talked about is the data science there in the middle for that overlap of the Venn diagram, and how we take structural human resource approaches to that at the organizational level.
Thank you, Jim. And I agree. And Jolie?
Yeah, I was just going to reinforce, because I think you had sort of said, like, what's the policy ask? And, you know, Civitas for 3 years now has been working both at the federal and state level to educate, you know, policymakers about this sort of expansion of value-added services from HIEs and the sort of emergence of health data utilities and the potential that they bring to bear. And I think this is just another opportunity to give a sense of assurance to states that, you know, because this is all moving so quickly. So if they're in the place of thinking like, oh, we have to start from scratch, like there is actual existing infrastructure that we can already build from. And there's so much to be learned, knowing that, you know, however many years ago when we were back at just sort of thinking about digital health data moving in a way that it was, like, there's just a tremendous opportunity to learn from that and apply that to health AI. I see Dan's hands up, so I'll stop.
100%. And Dan?
So I would add that we have to find a way to measure AI's impact on transparency and trust.
Yes.
And that is both at the individual patient level and the provider level. And that's kind of soft and qualitative, but AI really must be measured at the impact of transparency and trust. Thanks, Timmy.
That's super. And I'm going to try to wrap us. Clearly we were being very bold of tackling AI in one workshop. So our team will take this conversation. I think we are just on the start of our journey here, but we will really endeavor to be able to have some clear policy priorities by the beginning of the year that can really be help inform the work that we're going to do next year. So I think what we'll do is take this discussion and really start refining what's around this Venn diagram and be able to shape those policy priorities. We'll take it to our advisory group and to our board, and then land on this by the end of the year. I really, really, really would love to welcome all of you that are here today to be able to follow up with us with your insights, where you're seeing other innovation that we should be bringing to the table. And I'll also just add the keywords that I was also hearing and learning about today, that public stewardship should be added. I just think stewardship is such a strong word and notion. The explainability piece, I think that brings you right back to the trust to the providers and to the members and patients and those of us that are interacting, Dan, to your point. And then we have access, but not equity. We need to have equity here too represented. So those are kind of my key takeaways. Yes, we're moving really fast, really, really quickly. Thank you, Shirley. Not shameless, but if everybody could put that on your calendar, and hopefully we can continue the conversation there as well. We're going to go to the last slide to be able to make sure that you all know what's going on, because there's a lot right now as we're on the road. Olivia, why don't you just kind of walk through very quickly so that everybody has this on their calendar.
Perfect. Thank you, Shirley, for adding in ITEP's annual conference, which is coming up in February, but ITEP also has an election policy forum happening next week. The DXF is moving forward with a few different meetings as well. We have a standards committee meeting on the 28th, an IAC implementation advisory committee meeting on November 7th. And also the technical advisory subcommittee has been busy doing work too, and they'll be meeting on November 8th. Stephanie, I know, has been working very hard to support California's Telehealth Policy Coalition and eConsult Work Group annual meeting in Sacramento. It was a great meeting last year, and I know that there was so much great discussion around digital health, telehealth, eConsult there. So recommend, if you're in Sacramento or can travel there, go check it out. And finally, to wrap up the year, we've been keeping an eye on the ONC, or now ASTP, annual meeting out in DC. So these are the events we have coming up.
And Kamal, I think you saw the many asks for your deck. So hopefully
I sent it already to Stephanie.
Oh, you did? Okay. So we will send that out to our distribution list. We'll put it in our newsletter as well to refer to it. Thank you, everyone. Thank you to our speakers today for joining us. Your expertise is incredible. It's a gift to us. We will be following up and helping to advise as we go forward. So again, thank you so much. Appreciate you all.
Great
Thank you.
job, everybody. Thanks.
Thank you all.